So my name is David Enoch. I'm a microbiology consultant from Addenbrooke's Hospital in Cambridge, and I'm an antifungal lead in Addenbrooke's Hospital. I'm also the infection control doctor, and I've also got an honorary role at the University of Cambridge. So I've been asked to give a talk about the diagnosis and management of Candidaemia. And basically, as a brief overview, I'm going to talk about the epidemiology of Candidaemia, go through some of the clinical manifestations of Candidaemia, a little bit on the laboratory diagnosis, and then the treatment and management of Candidaemia as well. And so basically, if invasive candidiasis is described as the most common fungal disease among hospitalized patients in the developed world, and if we think of invasive candidiasis, that's deep-seated tissue candidiasis. So that's where we manage to isolate Candida from normally sterile sites. That's blood, joint fluid, CSF, that sort of thing, cerebrospinal fluid. Candidaemia is when we detect Candida in the bloodstream itself. And this can either be direct inoculation, so the Candida is found in the actual tissue, or it can be via hematogenous spread via Candidaemia. So what I actually thought I'd do, since I'm talking to people from Ghana rather than from the from the UK, which is probably what I'm more used to, I found this. I put PubMed search of Ghana and Candidaemia. And I found that I've said that it's the most common cause of invasive fungal disease. Actually, in Ghana, it's not. And so, according to this, you had 1,400 cases of Candidaemia a year, which is still pretty high, I think. But actually, it's not when you compare it to cryptococcal meningitis or PCP or even histoplasma. You've got twice as many cases of histoplasma. But if I give you some context to that from a UK perspective, in Addenbrooke's, which has got a big, well, I say big, it's got we treat patients with HIV, transplants, hematology patients. Despite that, we probably only have about 5 or 6 cases of cryptococcal meningitis a year in Cambridgeshire, and we get them from across the east of England, so a population of about 5 million. We might get 20 or 30 cases of PCP, and in 20 years in microbiology, I've only ever seen 2 cases of histoplasmosis. So I appreciate that there's a geographical distribution, but it's quite different epidemiology. So I'm afraid my epidemiology slides may not be that appropriate to you, but I'll go through them anyway, just to examine some of the differences, I guess, really. Oh, and then fungal keratitis is at the bottom of this with 800 cases. Again, I guess I've probably seen about 10 of these cases, and I've probably seen about 10 cases of mucormycosis in the last 10 years. So we don't get many cases at all, really. Anyway, never mind. So bearing that in mind, there are several problems with studying the incidence of invasive candidiasis and Candidaemia. And one is actually the sensitivity of most blood culture systems, which typically we think is about 50%. And this is even with the most advanced automated systems such as BACTEC or BacTalert or something like that. It depends on how much blood you actually put in the blood culture bottle. It depends on whether you're using an automated system or not. And then obviously whether the patient's receiving antifungal agents. And whilst we use things like beta-D-glucan, mannan, anti-mannan, and also nucleic acid amplification tests like PCR, because if we do these tests and we find a positive result, quite often we'll start treatment and then we'll do the blood culture afterwards. So you might actually be getting false low rates of Candida in the bloodstream, if you see what I mean. So it affects the sensitivity. So as I said, Candidaemia is often cited as the 4th most common cause of bloodstream infection. And I think that's probably predominantly in ITU patients rather than general patients. And a lot of these studies are from teaching hospitals rather than from district hospitals. So it's a bit variable. And the incidence varies from 1 to 14 cases per 100,000. And in that study that I in slide number 2 from Ghana, your instance was about 5 per 100,000 in Ghana. So you're middle of the road, which isn't a bad place to be honest. It suggests that you don't have too many, which is good, but it also suggests that you're picking them up. On the lower end of the spectrum, I tend to think that there's a source of bias, and maybe you're not doing enough blood culture or something. So I think that's a good place to be. Changes over time. Well, actually, most of the papers until a few years ago suggest that Candidaemia was going up over the last few decades. And that's because we're giving more patients are receiving chemotherapy, more patients are undergoing transplantation, and more patients are receiving intensive care. Certainly our intensive care units doubled in size in the last few years. However, there are some recent studies that suggest that this rise in incidence is actually dropping now, and it might actually be falling. And actually that's probably hospital associated cases rather than community onset cases, and that's probably because of better care in terms of managing patients with central lines, central venous catheters, and also, as I said, if you're using biomarkers such as beta-D glucan, you might actually be starting treatment earlier, and so therefore the incidence of candidaemia is falling. So it's quite changing. There's also geographical distribution. As we said, in Ghana, you don't seem to get many. Predominantly Candida albicans in the West and in the UK and in the US, but non-albicans Candida, such as glabrata, parapsilosis, tropicalis, krusei, that sort of thing, they're gradually increasing as a proportion of cases, which has obviously got issues. In terms of risk factors, traditionally it's been neutropenic patients with cancer or leukemia, but now actually the incidence predominantly is affecting critical care patients on intensive care units. And in the UK, about 40% of cases are on intensive care units. And there's also new sort of risk factors that are emerging all the time, like defects in toll-like receptors and the like. So these are just some of the risk factors. This was a review that I wrote a few years ago about what are the risk factors for candidiasis, and you can read that at your leisure later on. Whether it's fungal colonization or steroids or presence of a urinary catheter, yeah, they're well described. In terms of mortality, well, candidaemia is associated with significant mortality. In some studies, say up to 60%. And if they've got septic shock, it's up to 90%. But typically it ranges from about 20 to 50%, with an attributable mortality of about 15%. So it is a significant cause of death. And again, there's differences in terms of organisms. Typically Candida krusei, which we'll come back to in a moment in terms of resistance to azoles, has got the highest mortality generally. But then other studies suggest that Candida albicans has got a high mortality too. So there seem to be geographic differences and differences in organism as well. So coming on to resistance, so there's intrinsic resistance, to which a number of organisms have got intrinsic resistance, but then there's also acquired resistance, where the patient might be on an antifungal agent and then resistance develops whilst on treatment. So fluconazole resistance has been recognized for several decades, really. Candida glabrata is one of our commonest causes of candidaemia. And azole resistance, typically fluconazole resistance, has been well described in that. And actually you can generally overcome that with high dose fluconazole. You know, it depends on the MIC, but you can generally get over it. Whereas Candida krusei, fluconazole just doesn't work. Resistance has emerged in Candida parapsilosis, and again, predictors for fluconazole resistance are fairly sort of explanatory, really. If you've been on fluconazole before, that makes sense. If you're neutropenic, quite often you're on fluconazole exposure. Also, if you're neutropenic or on intensive care, you've got problems with kidney function as well. And then antibacterial agents, again, you're more likely to get azole resistance as well. I think all of these merge into one sort of problem. They're not mutually exclusive. There are two mechanisms responsible for most azole resistance in Candida, which is reduced affinity for the target enzyme and overexpression of efflux pumps. So either the azole gets into it but doesn't work, or it gets pumped out before it can work. And this is mutations in the target enzyme are encoded by the ERG11 gene. So again, you can read that at your leisure. In terms of echinocandins, well, these are probably much more newer agent. They've been around for about 20 years now. It's been increasingly recognized, and this is due to mutations in the FKS gene, which again, it's target modification basically, and resistance has been shown to emerge on therapy. We haven't seen any resistance emerge on therapy in Addenbrookes, and echinocandin resistance in Cambridge is very rare. I must say, we don't see it very often, to be honest, but it's in the literature, it's rising. And then the other thing, so Candida parapsilosis has generally got a raised MIC. Glabrata is also sort of slowly emerging, and Candida kefir, which we've not come across in Cambridge, can also exhibit it apparently. So in terms of clinical manifestations, the clinical features of it, well, that depends really on the source. So the source traditionally has been the patient's own flora. So typically it's bowel, it's intra-abdominal, and then there's been maybe a tissue perforation or something like that. You know, or it's mucosal candida that then managed to get into the bloodstream. It can be a central line, but again, you know, mucosal or skin damage, and it gets into the bloodstream that way through the central line or down the edge of the central line, and then urinary tract typically associated with urinary catheterization. The clinical features obviously can be either local signs, you know, or they can, you know, which again depends on the source or the spread. So, you know, you might get redness around the central line. You might get pus coming from the urethral catheter, that sort of thing. But obviously there's overwhelming sepsis as well. So that depends on what happens really. In terms of laboratory diagnosis then, as I said, Candidaemia is defined as the presence of Candida in the bloodstream. The picture on the left is a BACTEC machine, which is what we've got in our lab. I think we've got about 8 of these machines in our lab. As I say, we're a big lab, regional lab with about 1 million samples a year. So we've got 8 of these machines, and these have several hundred blood culture bottles on them. The sensitivity still remains at about 50%. Identification, I've got some slides coming up with some of the things that we do, but the picture on the right of your screen is a MALDI-TOF, which is what we use for identifying pretty much most of our bacteria and most of our fungi now, and that's a mass spectrometry system. So that's sort of based on culture, but then obviously there are other non-culture methods, as I've said. So serology, there's beta-D-glucan. There are also molecular methods such as PCR as well. So traditionally, culture, if we suspect fungal infections, we'll put a sabro-dextrose agar, possibly with chloramphenicol on, and that is the picture to the left of the screen, and that's what the colonies typically look like. The middle picture is blood agar, and this shows Candida albicans with the typical spiking appearances. It's not a nice smooth edge to the colony. It's this sort of rough, crinkled edge, and that actually is quite suggestive of Candida albicans rather than the other Candida species. And then top right, or the 2 pictures to the right rather, showed germ tube formation, and Candida albicans is in A, so bottom left of the black and white picture, which shows Candida albicans, and then to the right is typically Candida tropicalis, and then other Candida don't show germ tubes. So that's what we still use in Addenbrookes when the MALDI-TOF breaks, which obviously doesn't happen very often. Probably should be careful. So culture as well, I don't know whether you've got this in Ghana, but we also use these chromogenic plates, and these are typically selective media. So they've got sort of sugars in to enable the Candida to grow, and then antibiotics such as chloramphenicol. But then there are dyes that the typical organisms change color, and you can see that Candida albicans is typically green. Candida tropicalis is a nice purple color. Candida krusei is a nice lilac color, and it's quite nice. It's good for showing different colonies. If you've got a mixed Candida species, if you've got, say, intra-abdominal pus or something like that, it's quite good. There are different manufacturers, so Biomeria and Oxoid have different ones, so the colors can vary. And we would usually confirm this with moldy, so we wouldn't necessarily believe that the lilac one is definitely a Candida krusei, but it's quite nice anyway. In terms of, so that's what we do in Cambridge. In terms of susceptibility testing, susceptibility testing can be very difficult with Candida, but it's really quite important to do. So bottom left is typical disc diffusion. Yeah, we struggle with that in Addenbrooke's, and various organisms can cause problems. You can get sort of trailing growth and things like that. Along the bottom are e-tests, which is how we get an MIC. And again, we have problems. If you look at H, you can see that actually that there's growth right up, but you ignore some of the growth, if you see what I mean. That there's this problems. And then if you look at E and F, it's quite difficult for the biomedical scientists to decide where the break point is. Whereas G, I think, is quite clear, and D is also quite clear to me. Even I can work them out. At the top of the screen shows a broth microdilution method, which I've used in the past. We actually use sensitivity to yeast 1, which I think is probably quite good. But again, the difference between the purple and the lilac, so one is sensitive, one is resistant, can be quite difficult in real life. And so we have problems. We actually use a Vitek system here, which is black box technology, where you just literally get a number and an answer, and it's not particularly clear how it works to me, but we seem to we believe the results. It's a CLSI and UCAST approved method. So there are various guidelines around there. There's European guidelines, there's US guidelines, there's probably British guidelines, there could well be African guidelines. I tend to use the US, the Infectious Disease Society of America guidelines. They haven't been updated for a few years, but I think that they're pretty clear and pretty straightforward. So this is what we tend to aim for. And the reference is there. So, and it's on PubMed, it's quite easy to find, and it's free. Basically, what you need to do is that you need to start an antifungal agent promptly. So as soon as the, well, as soon as possible. And actually, we say that we need to get the antifungal started as soon as we get a positive, you know, as soon as we see yeast on the gram film, we phone the result out to the clinicians and they start an echinocandin. As you know, we want it within 2 hours, really, of diagnosis. Ideally, you've already suspected it, or you've had positive biomarkers such as beta-D-glucan, so they're on treatment already. But that's not always the case. Once you've started the treatment, you then need to think about clinical assessment for where you think it's come from, whether it's a line, whether you think it's intra-abdominal, whether you think it's urinary. So you need to get samples, you know, from lines, etc. We need to do repeat blood cultures every 48 hours until we get a negative set. And the reason we insist on that is because that determines duration. For a simple, uncomplicated Candidaemia, we give 2 weeks from the first negative blood culture. So if you don't get a negative blood culture, either because you haven't taken one or because you haven't persistent source, you can't, you know, it's difficult to, you know, to give advice on when to actually stop it. So we'd say every 48 hours. Some studies or some centers do it every 24 hours, but I don't want to really make the patient anemic, especially since these patients will have blood tests for lots of other reasons. We also advise the removal of central lines within 3 days in non-neutropenic patients. We also sometimes suggest in neutropenic patients, although I've got a bit of a high threshold for that because obviously it could be a mucositis or intra-abdominal source. That's more likely in a neutropenic patient, but they certainly need to assess the line. We also usually perform an echocardiogram, whether that's transthoracic or transesophageal. We're looking for endocarditis, which can be quite nasty. And typically needs valve replacement. If it happens, it's rare, but it does happen. And then the other thing is you should be doing dilated fundoscopy to look for endophthalmitis or retinitis. And that can cause problems in prolonged therapy and things. So it does make a difference. Treatment, and this is straight from the IDSA guidelines, start an echinocandin, strong recommendation, high quality evidence. That's what we start. We rarely start fluconazole now. We tend to start that in patients who've never had an azole before. Possibly we're in patients in whom we can't get a line, so we have trouble getting IV access. This can be sort of, say, IV drug users. We seem to have a bit of a problem with intravenous drug users, where line access is very difficult, and they're treatment naive, so they might have had antibacterial agents before, but rarely they've had azoles. We do that occasionally, and I've got some data in a few more slides to say how rare that is. We do, however, switch from echinocandin, which is quite an expensive drug in the UK, to fluconazole. We generally switch as soon as we get the sensitivity results, to be honest. I think it says day 5 in the IDSA guidelines. And as I've said before, 2 weeks of treatment, provided there's no metastatic spread, and provided things are getting better, and you've got negative clearance blood cultures. Voriconazole and amphotericin B formulations are in the guidelines, but we tend not to give them empirically because of side effects and toxicity and TDM issues. Neonates, you need to think about performing a lumbar puncture, and then you might want to think about imaging the abdomen to look for a source, you know, as I say, and then CVC, central venous catheter removal, strongly recommended. So basically, we did a study a few years ago within Cambridge about how did we manage patients with Candidaemia. And basically, as I said, this was a few years ago. In 2009, 2010, we had a mortality at 1 month. So this is crude mortality of about 27, 30% or so. And we decided to, and then we introduced a care bundle where basically we introduced, do we give appropriate therapy straight away? Do we remove the line? Do we perform repeat blood cultures? Do we do ophthalmology and echocardiogram and things like that? In the historic data, we did it 30% of the time. When we sort of nagged people and told them to do it, we did it 87% of the time. And actually the mortality at 1 month dropped from 27% to 9%, which statistically wasn't quite significant, but we thought it made a difference anyway. So we've continued with that approach. Just a few slides on Candida auris. So basically this is, I would say it's an emerging infection that's worldwide. It's responsible for a wide range of healthcare associated infections. It's been reported, as I say, across the world from India, South Korea, South Africa, and Europe. There are various problems with it. It's caused a few outbreaks. And as I said, Candida typically is sort of infection from your own, from your own floor, if you see what I mean. This has been demonstrated to spread between patients. It's also been demonstrated to live in the environment for long times as well, which is unusual for Candida. It's also intrinsically resistant to fluconazole, and it's also got raised MICs to amphotericin B, and echinocandin resistance is emerging. It can also cause problems in terms of lab identification. So upgraded MALDI-TOF systems work, but some of the chromogenic media and Vitek and things don't work. So you need to be a bit aware of that. This is just one of the outbreaks that occurred in the Royal Brompton, which is a hospital in London. It deals with cardiothoracic patients, so heart and lung transplants and patients with heart disease and lung disease and things. They had 50 cases. Quite a few patients had Candidaemia, about 9 out of 50. There was lots of environmental spread, and they had to shut their cardiothoracic intensive care unit to get on top of it, which is obviously a major problem in a London hospital. They tried to isolate patients. They wore personal protective equipment. They screened patients. They even did skin decontamination as well. They cleaned everything with bleach, and then they eventually used hydrogen peroxide vapor as well to try and decontaminate the environment. There have been other studies in Oxford as well of outbreaks that were related to blood pressure cuffs and poor cleaning. So that is an emerging problem. So in summary, I've said that it's a common infection, and it's obviously associated with significant morbidity and mortality. There are new and emerging strains that are developing. Resistance is becoming more uncommon, and therefore I think it's an important topic to discuss, although I appreciate there are other fungal infections too, particularly in Ghana, which maybe I could hear from you guys later on about. And then management is difficult, but I think it's worthwhile doing properly. And if you do it properly, then actually you can improve outcome. Thank you very much.